Guten Tag. My name is Bob Wilson. I'm an interventional cardiologist in Minneapolis. I'm one of the developers of the EGNEST radiation protection system. I appreciate the opportunity to introduce the system to you and really appreciate the invitation by Dr. Axel Linka. First, I want to show you a little bit about why we developed the system and a little bit about scatter radiation in general. To do that, I'm going to share my screen here, and here we go. There we go. Great. So I know you're all familiar with the concept of scatter radiation. I just want to share with you a couple of things that I was very surprised at when we started making a lot of measurements. The first thing is that only about 1 to 3% of the photons that come out of the primary beam, out of the tube housing, actually make it to the detector to make an image that you can see on the screen on the right. Over 97% of the photons are either absorbed by the patient or they're reflected in the room and create that big scatter cloud that surrounds the patient. So you can think of the patient as being an X-ray beam reflector. Another interesting thing is that we found that about 18% of the scatter radiation in the room doesn't actually come off the patient. It comes directly from the tube housing and the beam that's outside the primary beam. If you put a lead enclosure around that tube housing, you'll find that scatter radiation in the room drops by about 18%. So most of scatter radiation is from the patient, and the patient's taking the biggest dose, but the room is really lit up around the room by radiation. And it turns out that interventional physicians have a very high dose of radiation. They have the highest radiation exposure of any profession in the world, almost 3 times that of a nuclear power plant worker. And you might say, well, does that make any difference or not? And, if you want to know whether 30 years of daily exposure to radiation has an effect on your health, you have to wait 30 years. And that data is in now. And that data indicates about a 3-fold increase in the risk of cancer, predominantly hematologic malignancies and brain cancer. Cataract risk is about 6-fold. Cardiovascular risk is about 2-fold. The left carotid in most intimate and most interventionalists is thicker than the right carotid because the endothelium is very sensitive to radiation, and the incidence of hypertension is significantly higher in that group as well. And then, of course, the usual skin lesions and other things you would expect with prolonged radiation exposure. But I think a lot of people think, really, is there still a problem? And I just want to show you a couple of KOLs and what they think about it. And I don't know if that'll shape your opinion, but it certainly did mine.
I don't think any interventional cardiologist doesn't sometimes at night lean back and think about what would happen if they get a glioblastoma of the brain, because you hear about people getting that. And that's, I would say, every interventional cardiologist's fear. And certainly we worry about other people in the cath lab as well, nurses, techs, and so forth. And for all of those things, but particularly we're there next to the radiation source, right to our noggin. So certainly something we're worried about.
I was kind of aware, and I would take the appropriate precautions that we're all guided to do. I'd be wearing my LEDs. We have the radiation badges, but you never think it's going to happen to you.
Well, if you look at nuclear power plants, or an interventional cardiologist, the average interventional nuclear cardiologist will get probably 3 to 5 times the radiation exposure of a nuclear power plant worker. It's difficult to assess, but we all know it's real. Similar to the NFL concussion problem, everyone knew there was a problem. Some people didn't want to face there was a problem, but we all knew there was something there.
I get asked to do lots of complex procedures all the time in lots of different hospitals. And I think I would say no now. If you can't put in place radiation protection, I'd say no. I don't think I should be making those choices. It's my health or the patient's health. Now, the fact we're even talking about this shows that actually maybe some awareness of the problem is poking through. And the hope is that that will lead to some commercial opportunities where people see, well, there's a problem, there may be a solution.
So when we started this journey, we had to figure out where the scatter radiation was. And, there's published data, but it really isn't granular enough to be able to create a system to significantly intercept all of these X-ray photons that are coming at you. So we developed a testing model using a phantom that we got from the United States Department of Energy that scatters just like a person. And we measured scatter radiation at 6 points around the X-ray table where people typically stand, where the echo person would be for structural heart or the implanting EP doc, where the anesthesiologist or nurse would be right behind the patient's head, where the scrub nurse is, the circulating nurse a meter and a half away from the table, the operator for femoral radial access, and the assistant, the radiology technician next to the operator. So what you see on the left is what we found. The blue bars are the average scatter radiation dose from the floor to 2 meters up. We measured every 20 centimeters in that 2 meter height. And the red bars are the peak dose anywhere in that 2 meter height. And that typically is around the mattress or just below the mattress. And what you can see is that the head is very hot. The three positions around the head have the highest doses. And we believe that's related to the fact the scapula are pretty good X-ray reflectors and they create this halo around the patient. The operator is next in dose. The rad tech next to the operator actually has the lowest dose of anybody in the lab, partially because of the distance of the pedestal, but also because the pelvis is actually a shield for that person. The nurse, a meter and a half away, actually has a higher dose, almost double the dose of the rad tech standing next to the doctor. This is the vertical distribution of scatter radiation in the lab for each of those positions that we talked about. The X-ray table here is set at a meter. Each one of the blue bars is a scatter radiation measurement from the floor to 2 meters up. And what you can see is that in bulk, a little over 2/3 of the scatter radiation is tabletop and below. A little under a third is above the table. There's some variance from position to position, and as I'll talk about later, from angle to angle. But in general, directionally, this holds. Below the table is hot and much hotter than above the table. Now, you're already probably using some standard shielding, and it's not that it's bad, but an X-ray apron only covers about 60% of your body. Obviously, it doesn't cover your head, arms, and legs. And in the woman, it doesn't cover the lateral aspect of the breast either, which is right by the hole where your arm comes out. Leaded glasses are great, but they only work if you're looking at the X-ray. And of course, most of the time you're looking at the screen, so the X-ray comes up in an oblique angle. Kevin Federle at Mayo Clinic has looked at the no-brainer cap. It drops your brain dose by about 3%. It's great for cosmic radiation coming from above, but when the radiation is coming from below, it's really not very effective. And then, of course, there's rad pads and all of these other kind of spot shields. And, they're effective for reducing radiation for a part of your body, but not for a lot of it. So your badge dose, if it's in that area, may drop a lot, but your total body dose probably doesn't drop very much at all. Lead equivalent is an important concept. Now, most people wear lead equivalencies for their apron that are between 0.25 and 0.5 millimeters. It's important that 0.25 millimeter lead aprons let through about 19% of the photons. So it's a filter, it's not a shield. And there's still a substantial radiation that occurs directly through that lead apron. So when we started this, we had 3 simple goals. The first was a 90% reduction in scatter radiation compared to standard shielding. So 90% further reduction, because that's a big number. The second was we wanted to protect everybody in the room. And the third is you have to work with the existing workflow. People don't change their workflow in order to have more radiation protection. So we started out with this EggNest XR base platform. It's a carbon fiber shield. And that replaces our carbon fiber sled that replaces the mattress on a table. Inside that carbon fiber sled, as you can see here, we have internal shielding because the mattress turns out to be a pretty big emitter of X-ray. And there's a rail system, which I'll show you the purpose of in just a second. We use carbon fiber because it's strong, it's light, it's radiolucent. And then into that carbon fiber sled, we put a mattress, an under mattress, which you can see here for patient comfort. And then there's a very rigid area right around the chest as a built-in CPR board. That sled is placed on the table, takes just a couple minutes, straps on, and then onto that sled, we just mount modular components. Below the table, we have what are called flex shields. The flex shields have stays within them, wire stays, that allow this to flex forward with the X-ray gantry, but without interacting with the tube housing and, more importantly, the tube housing detector. Above the table, we have what we call flip shields. These are flipped down for patient loading, flipped up after the patient is on the table, and then they go under the drape. These take care of the radiation photons above the table. And then finally, we have what's called the clear spot shield. This clear spot shield goes in front of the abdomen. Turns out the abdomen is a big source of operator radiation exposure, and the standard hanging shield that you have doesn't really get over to that area. So this blocks all that stuff that's coming off the abdomen. So, you know, it's modular, it moves with the workflow, and it's designed to work for optimal imaging with the C-arm. We've done a lot of bench and clinical testing with the device. The average radiation reduction around the table is 91%. There is some variance from position to position. The EP implanter or echo position here, position 1 has about a 97% reduction. The operator has about a 92% reduction. The circulating nurse about 92%, about 89% at the head of the table where the anesthesia person is. And this is data that's in the PA projection. We obviously have looked at all of the angles, LAO, RAO, caudal, cranial. And those numbers are basically the same. In each one of the angles, the average protection is 91%. The protection in each position is going to vary a little bit, you know, of course, depending on how the patient is placed and angulated. Just to give you an example of that, we created an index of total room scatter radiation. So the total amount of radiation in that room, the volume of radiation. And you can see that here in the PA projection and then in the angles. The blue bars are no shielding. The light blue bars are standard shielding, and the green bars are the egg nest. And what you can see is that, you know, standard shielding, if you look at the PA, you know, it's got a modest effect. It's really not intended to suppress room scatter. It's really just intended for one person to stand behind to get a shadow. And you can see the egg nest has an enormous suppression of total room scatter, which is designed to do. As you angulate the X-ray, you can see how much the dose in the room, the volume of radiation in the room goes up. And when you get over to LAO caudal, you can see how dramatically the levels rise, almost fourfold that of a PA projection. And again, standard shielding has a modest effect, and the egg nest has a 91% reduction in scatter radiation, even in that position. The egg nest is made to really fit the workflow, and this was the biggest lesson in designing the system, that if it doesn't fit the workflow, it just doesn't get used. You can see it here on the left in the patient loading position. The bed comes up, patient loads over. When the patient's on, the flip shields on the top come up, and the drape goes on, and you can see on the right the operator using the system. And the intent is to be, and our best compliment we can get is that you didn't even notice that it was there. So, you know, radiation, scatter radiation exposure in the cath lab is still a significant problem, and it's associated with important dose-related health risks: cancer, cataracts, cardiovascular disease, and of course, skin lesions and hair on the leg, and, you know, I could go on. Current shielding methods help. They're not bad. They're just not enough. The egg nest radiation protection platform protects everyone in the room without workflow interference, which is very important. It's not the only next-gen system, but whatever you use, you should be using some next-generation shielding system, because they're available now, and they can significantly reduce your dose. And what we call ALARA, the as low as reasonably achievable principle, that principle's moved. You can have more than 90% more radiation reduction now than you had 5 years ago. That's achievable, it's available, and we all should be using it. So thanks very much for your attention, and I appreciate the opportunity to introduce the egg nest system to you.